Welcome to today's webinar with the Accountable Care Learning Collaborative. My name is Scott Hammer and I'll be moderating today's call. We're excited about today's presentation. We have Joe Mott, Vice President of Population Health from Intermountain Healthcare with us. And of course, he'll be speaking about the population health activities at Intermountain Healthcare. We're looking forward to his presentation and remarks today. Just a few housekeeping items that we want to cover before we get started. To minimize feedback, please mute your line. If you are dialed in, please use your phone's mute feature. If you are using your computer only, click the microphone icon. If you are using both a phone and a computer, it is best to select the telephone option under audio in the GoToWebinar window, then mute your phone. We should have opportunities for questions, so please submit them using the questions box of the GoToWebinar window. So we're looking forward to that. Today's agenda will consist of the following agenda items. I'll discuss the member meeting coming up next week just briefly. Then I'll introduce Joe Mott, Vice President of Population Health from Intermountain Healthcare. And like I mentioned, we should have time to take questions from the audience, so we look forward to receiving your questions during and at the end of the session. Just as an update, next week is our ACLC member meeting, and so we're really excited for this event. On October 18th, we'll convene in D.C. from 1 to 5:30 p.m. for work groups. On October 19th, we'll convene for the broader agenda from 8:30 to 1, and as you can see, it's a great agenda. We're looking forward to this opportunity and having you join us. Small group dinners will take place on Tuesday night, and that agenda and registration will be announced in Tuesday's member email. So please look forward to that as it comes through your email. If you have any questions, please email us. If you cannot make it, we'll plan to send an email regarding next steps after the event. So we'll be sure to keep you informed on what's happening here. Looking forward to this event and look forward to seeing you next week. So we are doing this webinar here in downtown Salt Lake City, Utah, and we're also stationed in the backyard of Intermountain Healthcare. In fact, Intermountain's corporate office is just 2 blocks up the street from us. We've always been close to Intermountain, and we've been very aware of the great work that they're doing in healthcare. They're certainly considered one of the premier health systems in the country, and we're happy to have Joe Mott with us. The one thing to me is I've observed over the years that stands out about Intermountain Healthcare is their commitment to transforming the overall healthcare system. If you ask or observe them, you'll notice that they're all in with population health and making the healthcare system better and more efficient. They have a system-wide mission and objective to do this, and certainly Joe Mott is one of those leaders for Intermountain Healthcare that is guiding this population health effort for the organization, and we're excited to have Joe with us. Let me just give a brief introduction of Joe. Joe is Vice President of Population Health in Intermountain Healthcare. He has worked for Intermountain since 1985. Prior to his current assignment, Joe was the CEO of Primary Children's Hospital here in Salt Lake City. He received his master's degree in business administration and his bachelor's degree in economics from BYU, Brigham Young University. Joe, it's great to have you with us. Thank you so much for spending time, and I'll turn the time over to you.
Well, thank you, Scott. I appreciate being here. Thanks for that kind introduction. We're really happy at Intermountain to share what we're doing, what our strategy is, and the progress we've made. We certainly don't imagine that we've solved all this, but are happy to participate in the national dialogue so that we can continue to learn from each other. You can see on this title slide, I've got a background picture of a guy out in the wilderness with a map, and I guess that's a GPS device. I think that may be how many of us feel in healthcare right now, trying to chart a new course, figuring out what our destination is and how to get there. And so I'll talk about how we have been answering those questions at Intermountain and where we are on that trail. Before I jump into that, just a brief background on a little bit about Intermountain. For those that might not know, as Scott just mentioned, we are headquartered in Salt Lake City. We've got 38,000 employees. We're a not-for-profit healthcare organization. You can see we're an integrated system with 22 hospitals throughout the state of Utah and 1 in southern Idaho. We have 185 clinic locations managed by our medical group. We also have very strong affiliated relationships with clinics that are not employed by Intermountain. And then we have an insurance company here in Utah called Select Health. So with those, I thought it may be helpful to talk about our starting position as we think about moving to a population health strategy. One is that we have a pretty strong culture of providing high-value care. You may be familiar with Brent James, who's been with our system for decades and has really helped us develop systems, our processes, our clinical programs. They've been about creating evidence-based standards for years. On top of that, clinical programs I mentioned, we've had standard costing systems going back to the 1980s. We've got a really strong EDW, lots of data. We have the largest payer in the state. Our membership in Select Health now is approaching, I believe, 900,000 members, and the largest medical group in the state. So we have a lot of things going for us in terms of a starting point for moving into population health. Let me start by just reflecting a little bit about the environment in which we all find ourselves. As you see these things popping up on the screen, there are different things that are coming out from the government, different things happening in the media, different things happening with new novel competitors in healthcare. And it really can become quite dizzying as organizations are trying to sort through what's coming up, what's moving forward, what is mandatory, what is optional, what do I want to participate in. And I really love this statement by Merle. Anyone who isn't really confused doesn't understand the situation. For me, anyway, that seems to really capture what's going on in healthcare. There are so many things coming at us, so many options and alternatives, and really comes down to strategy selection time for organizations, whether you're a provider or a payer or a supplier to the healthcare industry. And I've built this little graphic that it really doesn't capture everything that we need to consider, but you know, we hear the term frequently value care or population health. And even within our organization, though we've been talking about this for a number of years, I frequently get questions, what exactly do we mean when we say value-based care? Is that the same as population health and so on? And I built this little graphic to try to help sort out our thinking anyway. In the bottom left-hand corner of this quadrant, you have care is paid for entirely based on volume. As you move up the left-hand axis, up the y-axis, this is where you begin to make your pay at least partially related to quality and or patient experience. And as you move out to the right or along the x-axis, you're beginning to pay for care other than just on a per unit or a volume base, but really a total cost of care basis or on a population basis. And then you can see spread throughout this space a number of payment models that people can choose to participate in. Some of these are actually mandatory. But anytime you move from the bottom left-hand corner, which is just totally free for service, and move either up or out, you're moving into what I would describe as a value-based payment model. Your payment is based on something more than just the volume of activity you provide. Now, we call our population health strategy at Intermountain our shared accountability strategy, which you can see in the top right-hand box of this quadrant. We call it shared accountability because we believe that to be successful, every participant in this dynamic is going to have an accountability. Certainly the providers will. We think the payers have significant accountability. We also think that plan members or patients have accountability to achieve success moving into the future. So you can see I've laid out in this space bundled payments. I kept those kind of down toward fee-for-service because obviously a bundle, you're paid for the bundle, but I'd step back and you think of a bundle as really as a volume activity. I've just bundled everything together around that volume. So for instance, if you got bundled payments for back surgery, you're still paid on the number of back surgeries you perform and so on. And then, we could debate where should these things be placed in the space. Should they be more to the right or more to the left? And I don't know. To me, it's not terribly important to think about where these things lay out, but to understand that there is this space along quality and patient experience and cost, and different models will really fit different objectives. So, for instance, bundled payments. Intermountain participates on a mandatory basis with several around the country on CJR. We really would prefer not to participate in bundles. In fact, appealed to be exempted from that. Not because we don't believe in taking risk or being accountable. You can see our end game or our desired state is the top right-hand corner of this, where we are taking full total cost accountability. Our sense is that getting there is very complicated and a lot of work. In fact, I've been in this role helping lead Intermountain to that space for 5.5 years now, and I'll be talking about the progress we've made and where we are. But we view bundles, for instance, as frankly kind of a distraction. They're certainly not the end game. And to be able to bring focus on a specific episode of care, you think about new quality metrics, new data exchange. Are you going to contract physicians, creating financial alignment around that? It feels to us a little bit like a distraction from achieving the strategy that we ultimately want to pursue, which is the total cost of care budget. But I put this up here because as I talk with a lot of organizations around the country, I see a lot of them, like the thinker here, kind of puzzling. Which one of these should we do? I've heard some ACO presidents say that we chose to form and become an ACO for the sole purpose of forcing our physicians to the table. We felt that this would finally be a model where we could get people around the table and start to collaborate on what we're doing. So there'll be a variety of reasons that people may choose what path they're going to go down. But I think that it's really important that people start with that question. Maybe you're familiar with Simon Sinek. His book, Start With Why. I really like this. He's got a terrific TED Talk on this. But I think that any organization, whether you're a provider, a payer, a supplier to the industry, I think we all got to step back and ask, why all this change in healthcare? Why all this notion about value-based care? Why the talk about population health? And what is it we as an organization are trying to achieve? And to me, and for Intermountain Healthcare, the answer is pretty clear. And I'll get to that just in the next slide with our mission statement. But I see a lot of people, a lot of organizations still struggling with what are we trying to achieve, and we ought to settle on that first, because that will then inform us on which of these payment models make sense for our organization and why, and in what order and at what pace. For Intermountain Healthcare, we changed our mission statement 2 years ago to this: helping people live the healthiest lives possible. And as you think about that, some people ask us, wow, that's a pretty broad mission statement. Does that mean you're going to be responsible for pollution or poverty or education? We know that there are a lot of things that contribute to or detract from health. And the answer is no, we certainly don't believe we can or will take on all those. But this does highlight very clearly the kind of delivery system and insurance products we need to provide around preventive care, around the preventing chronic conditions from escalating into more serious conditions. And this doesn't say anything about filling beds or OR schedules or scanners. This is about helping people be healthy. And so that's how we're trying to focus our delivery system and our insurance products. Now, there certainly is an awful lot we need to be doing in the space of what are the social determinants of health, and you're probably familiar with those, a very interesting body of work that talks about things like pollution and education and a variety of factors that are more significant contributors to health or lack of health than the healthcare delivery system. So we have a vice president of community benefit, and she's actively working with state health department, local health department, private agencies, looking at ways that we can participate in that dialogue, ways that we can participate with other organizations that will actually have an impact on these other determinants of health that are outside the delivery system. But for us, this comes back to this notion, and that is Intermountain Healthcare has been focused on quality of care really from our beginning. That's been our focus, and really we've been very concerned about getting the right clinical model. That's what our clinical programs do. They develop our evidence-based standards, and we work to deploy those so we can get the best outcomes. But we really had to step back and realize, even though we've also been focused on trying to make care affordable, we had to conclude that we really had not succeeded in that. I think we can show a lot of statistics where our care is lower cost than most anywhere else in the country. We have low PMPMs. We have low trends. We have a lot of metrics we can show where our costs are much better than a lot of areas. But we looked back at our own insurance company and looked at what our premiums were doing, and they were increasing at trends not dissimilar from most of the country. I know that they've attenuated a bit the last few years, but when we launched this 5-6 years ago, you could see, depending upon the market or the product, rates going up 6, 8, 10% or more per year. And we're really troubled to consider our community members sitting around the coffee table or the kitchen table thinking, how are we going to pay this bill? And as our CEO likes to say, the quality of the care doesn't mean anything if people can't afford it or can't get access to it. And so we launched 5.5 years ago our shared accountability, or our population health strategy, with the intent of continuing to focus on and improve quality outcomes, but with the belief or the intention that we really think we can bend that cost curve. Now, to bend the cost curve, what does that mean? That's a phrase we've all heard and probably we all have been using for the last number of years. Well, for us, it's the notion that, and by the way we're measuring our success in this, and this gets back to, again, the why. Why are we doing this? What are we trying to achieve? For us, it's about making healthcare affordable for our community. And I think for all of us, it ought to be about making healthcare affordable for this country. I'm sure that we are all very well familiar with all the statistics about how much we spend on healthcare. We spend more than any other country. We spend more of our GDP. We know how much Medicare is in financial trouble, Medicaid programs, and so on. And even with the Affordable Care Act, we know that commercial insurance continues to be extremely expensive. Our belief is that we can bend the curve, meaning bring down that growth in healthcare costs closer to, or hopefully at some point even get to, general inflation. So how do we do that? That's really that's the objective of our population health, is to bring our healthcare cost growth closer to in line with general inflation. And that's how we're organizing our strategy. That's our objective financially, is while we continue to push increases in quality to make healthcare affordable. You know, that brings up then this statement I like by Taleb. Awareness of a problem, that is, in our case, the cost of healthcare, or the increasing cost of healthcare, does not mean much, particularly when you have special interests and self-serving institutions in play. Now, he wasn't talking about healthcare. This is from his book, Black Swan, which is a fantastic book. But I think his point here is applicable to us in healthcare, and that is, on this next slide you'll see, when we launched our effort, we made an explicit goal for ourselves around revenue. This top line represents our projected patient care revenue as of 2011 when we launched this effort. And that shows what we projected our patient care revenue to be in Intermountain 2013, 14, 15, and 16. It's growing at about 8.5% a year. Now that's got population growth in it, so, and some membership growth, so some of that would be appropriate growth. It's also got healthcare inflation, and we know what pharmaceuticals in particular have been doing, but it's also got another factor in there that we had never isolated, measured, or really tried consistently to manage, and that's utilization. And as we stepped back and looked at this, it was hard to isolate or pinpoint, but we thought it looks like our utilization of healthcare is growing maybe 2% per year. That is, more healthcare per person per year, everything else being held equal. That's pretty consistent with all the national literature that suggests that over a third of the care provided is unnecessary, i.e. will not help the patient, i.e. not based on evidence. Now, that's not to say the hospitals and doctors are out there purposely or consciously doing this. It's that it's really, really hard to know what is the evidence-based care this patient should receive. And so our focus became, if we can define the appropriate care, we really think we can provide all the care our patients need. We're not going to ration or withhold anything that would be appropriate or helpful, and we can provide less care. That is, eliminate tests and procedures that are not helpful. And by doing that, we set a goal to bend that revenue line, or to bring that slope down. So you can see by 2016, that is, our target became that our patient care revenue would come in $700 million less. It's actually more than $700 million less than it would if we kept doing business as usual. So that line was our projection, and then our goal or our target for this strategy became the second line. I have no doubt that we could generate that top line if we wanted to. If we were a revenue maximizer, a profit maximizer, I think we could easily generate that line, but that's not our mission. That's not our intent. We're a not-for-profit organization, and we believe our objective ought to be provide the highest quality care of everything people need, and that's it. And so that became our target, and in fact, we are now on track to bring our patient revenue in line with this bottom number. So we are already collecting from our communities over $700 million less in 2016 than we would have if we kept doing business as usual. So that's progress we've made. That's our objective, and now it's continuing to put all the new tools and functionalities in place to be able to sustain this model. One thing I often get from people is, whoa, isn't this going to undermine the financial stability of your organization? Obviously a really important question, and something that we've worked very hard on. I mean, going back to 2011 when we launched this, we modeled out everything: patient care revenue, expenses. We modeled out our balance sheet, our cash reserves, days cash on hand, and we built a model that we believed that if we could manage all of this in concert, we could deliver this care at this level, at this revenue, and maintain all of our ratios and our financial strength as an organization. So we felt that that was our not-for-profit mission, and that's what's been guiding this work for us for the past 5 years. So then you dive in and say, okay, how do we start to do that? That's a great idea. How are we going to get there? And so we found this little metric in an article and outlined this to think about all of the elements that would contribute to the cost of an individual. So it really has these three components. What's the cost per healthcare process? What's the cost per episode? And then how many episodes do I have? And so really it's these first box here is how much does healthcare cost? What's it cost to perform an MRI or a lab test or what have you? It's these second two boxes that really get how much do we use? During a healthcare episode, how many tests am I performing? How many days am I in the hospital? And then to the right-hand side, it's how many times are patients having an episode? This gets into the wellness or the prevention. Our cardiovascular clinical program has for years focused on things like when a patient shows up in the emergency department, what is the best care that they need, and what is the order, and what's the time, and door to balloon and cath lab, and boom, 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 they got all that defined well and doing very good work. But then we also went back to them and said, hey, cardiovascular clinical program, you're doing a really good job with patients that show up in the emergency room with chest pain. Can you tell us if you can reduce the number of people showing up in the emergency department with chest pain? And, so created a whole new interest for them. Now, that's not to say that we've never had efforts or initiatives focused on prevention. We have. But what we've added here is now this is consistently part of the dialogue. With every care condition we look at, it's not just what's the best care to provide, but how can we prevent this from happening in the first place and putting those more consistently in place. And so that's really what our shared accountability strategy has added, is consistently and strategically managing the appropriate use of healthcare. So this really comes down to wanting to transform our entire delivery system from being a fee-for-service to a population health management company, from working on a discrete engagement to across the continuum. Now, one of the things that's been interesting, I mentioned the national literature about the degree to which people believe people are providing more care than is necessary, and we started this strategy going around our system, meeting with groups of administrators and physicians and posing this question: is more health care better? And I would say 4-5 years ago, I think most people believed the answer to this question was yes, or almost always yes. We also asked people outside the industry, patients, friends, neighbors, people in the community, and I think they almost always believed the answer was yes. But I think you're all probably well familiar with the literature, the evidence that's been coming out the last number of years. This is just one book. I think this is pretty good, by Shannon Brownlee, Overtreated, talking about the many, many, many instances in which the industry is providing care that's not helpful to patients. Now, again, I come back to the notion of why would we do this, and is it purposeful? And my belief and our answer is no, it's not on purpose. It's not, at least I hope it's not. It may be in some cases, I suppose, people just trying to drive revenue because they can. But we think there's really 3 fundamental flaws in the healthcare system. That is, as an industry, we really have a lack of evidence-based standards. I think there was a RAND study some years ago that estimated that we have nationally an agreed upon standard for what we should do something like 10 or 11% of the time. I think David Eddy estimates that we follow our evidence-based standards half the time. So it's not that physicians or hospitals are purposely ignoring standards or not following the standard. The point is, it's really, really, really hard to do. There's so much new literature that you need well-defined infrastructure to continually review the literature, cull through it, which applies to your populations, get those defined, get standards written that can go into order sets, get those deployed, get the right staff deployed, the right information, the right tools, the right supplies. So it's really, really hard work to provide evidence-based care. Now, that's what we've been trying to do at Intermountain. I mentioned our clinical programs, that's what they do, and we think that we're doing much better than the national averages or standards on this, but we believe we still have real opportunity to improve in this area. But that's one area then, how we get out. This is more consistent use of evidence-based standards. The second is engaging patients. Lots and lots of opportunity here. One of the first things I would hear from physicians was, well, this sounds great. You want us to go down this model, and you'll see in the next box I'm going to talk about financial alignment and physician payment. Physicians would often respond, well, how can you put us financially accountable when the patients go and do whatever they want? I mean, I can't control what my patients do. And, every provider has horror stories about this, and we hear them all the time. And we believe we, as a delivery system and as a payer, can do a much better job of engaging patients. I mean, I'm kind of embarrassed to have to admit that when I started this, I went and did a survey within Intermountain Healthcare and was trying to find out who all in this company provides patient education? Turns out 10 different departments. And so then you had to ask, wow, are all of those consistent? Are all of those consistent with our care process models coming out of our clinical programs? Are all of those consistent with our care management program? And so we saw, yeah, we can point the finger at our patients and put some blame on them. And I think there does need to be more accountability amongst our society generally. But there are a lot of things we can do as a healthcare industry to better engage patients. We can give better, more concise, more consistent, more easily accessible educational tools or materials. That's one thing. We also found that we have 700 people in Intermountain doing care management, spread across 3 divisions, not always coordinated. We can do a better job with that. And then there are all these digital tools, ways that we can connect with patients. There's shared decision making. So we've got probably 7 initiatives just on better engaging patients that we believe we can do more there. And then finally, aligning financial incentives. You know, when you're in a fee-for-service system, you know, whenever I would tell people that are external to the healthcare industry that there's care provider that might not be indicated, they're like aghast and shocked. They're like, what? Why would you do this? Are you just trying to hose us for money? I go, whoa, 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 wait a minute. You know, the fact that the industry has not done as much as is needed around prevention, for instance, that doesn't mean that providers or payers don't care about prevention. The fact is, people aren't paid to do that. Now, that also might sound a little like harsh, like, oh, so you're not paid to do it, so you're not going to help me? No. What I mean is we don't have resources to do that. We get paid to do this MRI. We get paid to perform this surgery, and that payment has to go to pay for those activities. There really hasn't been money in the system to focus on more engagement and wellness and prevention. And, you know, as physicians in hospitals get paid when they provide a service or fill a bed or fill a schedule, and they don't get paid when they don't, we really have to shift that financial model to create alignment around a population health strategy. I mean, you can sit down with a group of orthopedic surgeons and say, you know, we know that we've been providing knee replacement surgery based on all of our own best judgment, and we're not going to second guess that or say that it was wrong or faulty, but now that we're looking at the data, we can see that there must be a number of standards in our heads collectively because it looks like the performance is quite variant. So we've come together, we've looked at the data, we've agreed on a standard, we now have a standard that we can deploy, and by the way, it shows that some small percent of these patients may not be candidates for knee surgery. And the surgeon says, yep, I agree, that makes sense. I'm not going to operate on that patient until, you know, they go to PT or they lose weight or whatever our new standard is. But when I adopt that, didn't I just lose $1,500 of professional fee income? And physicians are appropriately concerned about, even though this makes sense and they're on board and they support it philosophically, what will this do to me financially? And so we've deployed what we call our physician payment model. And like most people that are doing work in this space, our payment model reduces, and by the way, it's still largely volume and on a fee schedule, but we've reduced that to a degree so we can add money back for quality and patient satisfaction. Now, what a lot of people are doing nationally around the cost element is having specialty-specific cost incentives, maybe around bundles and things like that. Some have gone back to PCP gatekeepers and so on. We've believed that we really want our entire community working as a team, working collectively. We're all in this together. And by the way, if you start divvying up a capitation for neurosurgeons and orthopedic surgeons, you then get, well, is this back surgery patient in your pool or my pool? And we didn't want to start just creating different venues for misalignment incentives. So we have one financial metric, and that is It's a population. We divide our company into geographic regions where patients normally get their care within these regions. And we have a budget. So here's the Medicare population, here's the budget, and for all the performance on that, the physicians participate equally. All the specialties, whether you're employed by Intermountain or not. 1/3 of that product performance is shared back with physicians. So we say, yep, you lost $1,500 professional fee income for not doing that surgery, but you just saved the system $30,000, which goes into this pool. 1/3 of that shared back with docs. So that's trying to create a financial alignment so physicians can be financially rewarded for doing the right thing, even if that means less fee-for-service volume and fee-for-service income. So we're working simultaneously to solve for all three of these: evidence-based care, engaging patients, and aligning financial incentives. Now, on the payer side, you can see the financial incentive is we wish to go to the payer and say, we want to receive the medical expense budget for this population so that we can then align with our hospitals and our physicians so they're not just incentivized or paid or rewarded on volume. We want to bring them into a population health budget. So now that would change the dynamic with payers, and we're in discussion. We've obviously already done that with our own payer. I'll show you the numbers on that in a minute, and we're beginning to approach other payers in the market. So on the evidence-based care, I mentioned Dr. James and our clinical programs, continuing that work. Also in engaging patients, working with that. One thing that we often get asked is, wait a minute, if I start practicing differently where I might not order the same test or so on, am I not going to expose myself to more legal liability? And we've reviewed this at length with our legal counsel, and they say, you know, whenever we go to defend what we've done, it's based on something called community standard, and what on earth is that? It's you go out and you find some practitioners and ask them to say, this is the standard. What's that based on? It's on a physician's opinion. You give me a well thought out, evidence-based, literature-backed standard. Not only is that going to be the best medical care, that's going to be the best legal standard as well, so you don't need to be worrying about that. So then engaging patients, lots of work. I mentioned about 7 initiatives in there, then also around aligning financial incentives, commented on that. So then going on to the payer strategy. So I mentioned this is not just a Medicare and MA strategy or a Medicaid strategy for Intermountain. We want to provide what we view as a higher value healthcare delivery model to all of our patients. And so that means for us, we think we need to access these patients through all different payer vehicles or models. So for Medicare, our Select Health, that's our own insurance company. We've had a Medicare Advantage plan launched January 2013. We said no thank you to forming an ACO, not because we're not aligned with the objectives of an ACO. We certainly are. But we went through very carefully, and all the rules and mechanics in there, we just felt that we couldn't execute on the rules that they had implemented. So total alignment with wanting to be at risk for Medicare. We're continuing down that path. Medicaid, the state of Utah, the legislature created what they call a Medicaid ACO. It actually works very much like a Medicare Advantage plan. And so our Select Health insurance company has a contract with the state for over 90,000 Medicaid lives in much like an MA plan, also launched January 2013. On the commercial side, our insurance company launched a product in January of this year called Select Health Share, which is a commercial product based on these population health principles, and are out sharing that or selling that product in the market. And as I said, we're also now beginning to talk with other commercial insurers, hoping that we're able to engage with them on a population contract where we can take the risk for the defined population and receive that a population-based type of payment for them. Now, as we come back to this, though, I also remind everyone in our organization, though we've been talking about the finances and the contract and the payment, a shared accountability scope or our population strategy is much, much broader than financing. That's an important element of it, but it's really fundamentally changing the delivery of healthcare. Take utilization management. They're the arch of the bridge. That's historically an insurance company activity. And as we're moving financial risk from the payer to the providers, we really want to change the way we think about UM. Of course, payers have regulatory requirements around UM, but can we delegate some of that to the provider organization? Health promotion and wellness in the top left, select health products I mentioned, integrated care. All of these are things that we have historically had in a fee-for-service organization or are brand new. But whether it's, things that we've had historically were really built to operate in a fee-for-service world. What you ask in your capital budgeting process, your wellness, many of these areas is somewhat different in a population health world than you did in a fee-for-service world. So it's to tell our organization, and by the way, that's why we've been at this 5 years. This is not just a care management strategy. It's not just a shared decision-making strategy. It's everything. It's the earlier slide I said we're moving from being a fee-for-service company to a population health company, which means we rethink the way we do all of this. So this next slide, I'm not going to go through any of these rows in detail, but just to illustrate for you, we've organized this work into these different swim lanes: care delivery, contracting, population health services, physician contracts, and our team has been facilitating specific work plans in all of these areas, and most of these have sub-plans below them for the last 5 years on saying, to really transform our company, we have to be working in all of these areas simultaneously with significant deliverables in each area. So getting back to this question of now as we've taken this out to our delivery system and people are asking, so what is a population budget? And I get our medical group or even a particular clinic ask, how should I think about this? As well, we're organized in geographic regions in our company, and you think about people being spread across this space, this geography. These are our plan members. And so we also have our hospitals in this space. We have our medical group clinics. We have our home care facilities. And we have our affiliated clinics, those physicians that are not employed by Intermountain but have contracted with us and are aligned with their strategy. These patients or plan members will go to any or all of these providers within the space. They're not limited to go to one hospital or one clinic. And so it makes no sense to try to think about a population budget for a hospital or for a clinic. The population budget has to be thought about and managed on this region level. All these providers in this space together collectively are accountable for this budget. So in our old model, fee-for-service, Select Health being our insurance company on there on the left, they'd collect the revenue, they would have their administrative expenses, and then as providers would submit claims, that medical expense to the insurer became the patient care revenue in the provider side of the organization. In this new model, we want the provider organization to take financial accountability for care delivered. And so we have moved that medical expense element of 3 of our products, or 3 groups I'll show you in a minute, from the insurance company to the delivery system. So now as we provide care and submit claims, they're actually still processed by Select Health, but conceptually we're paying our hospitals and our clinics out of our own budget. So we now have the delivery system accountable for healthcare utilization. Now, of course, you can see the arrow going out to the right. That's for all the claims going outside of the provider system that we are managing. That's to hospitals or clinics outside our space, or to skilled nursing facilities or pharmacies. And so it's really getting this delivery system to manage that total cost of care budget. It's really at this region level, though, that you have to think about the population budget. This is what we've done so far. So these are all Select Health products to this point, again, hoping to engage with other payers. But you can see our Medicaid product, our Medicare product, and our Share product. Those are the 3 products for which we have activated the physician payment model. We've also moved the financial accountability for the Select Health fully insured large employer block of business to the delivery system. So you'll divide those member months by 12 to get the total number of members. It's over 300,000 lives and over $1 billion of medical expense budget for which the delivery system is now accountable. We had the Shannon Brown Lee. I mentioned her earlier. She was the author of that book, Overtreated. And she spoke at a forum here for us at Intermountain a while ago, a couple of years ago now maybe. She made this statement: the dynamics of the current healthcare system are stacked against changing it. That gives us all pause. I think she's obviously correct. I think the dynamics are stacked against us for two reasons, though. One is this industry has literally been built in steel and concrete for the last 50 or 60 years, all built around a fee-for-service model. That's hard to change. We have business systems in place, business processes, incentives. We know how to manage in that world. So just learning new competencies and new business systems and new processes, that's all really hard. So that's one thing that's stacked against us. The other, though, that's stacked against us goes back to the statement by Taleb earlier on, and that is, do we have self-interested organization? What is our interest? What is our mission? What is our objective as organizations? To me, this is pretty serious business. This is not just a new revenue model opportunity for healthcare. This is not just a way to reshuffle the deck. I think all of us involved in this industry have a responsibility to not only provide high-quality care, but to provide it in a way that's affordable to our country. And we believe that a population health model is the best model to do that. So I'd say the odds are stacked against us when we have people in our own industry digging in our heels and say, we're not going down that path if it's going to reduce my revenue. We're not going down that path if it's going to cost me market share. Now, I'm not suggesting people should not be worried about or concerned about their organizations or their success or their ongoing viability. Obviously, we should. But if we're resisting these changes because we're worried that it might bend our own revenue curve, I worry that we're doing a disservice to not only our members and our patients, but to the country. And I really like the way our CEO framed it. It's not only this is our mission. We have an opportunity here. Really, an opportunity does not come along very often. I think things are aligned that we can seize this opportunity. In fact, here he says it, that we have the responsibility. And that's how we framed it and how we're pursuing it in Intermountain. We love that there are so many others pursuing the same notion with the same objectives, and love to share our notes and partner with anyone else that's aiming to achieve the same result for the country. So thanks for letting me share our journey, and I'm happy to try to address any questions or respond to any comments that anyone might have.
Great, Joe. Thank you so much. This has been extremely informative, and grateful for your insights, sharing about Intermountain strategy and how you're going about this population health activity. We have some time for Q&A, so if you have questions, please indicate through the questions box in the GoToWebinar feature here. We can certainly take your questions. I certainly have several, and maybe one to start, Joe. So Intermountain's been thinking about this for some time. What, in your mind, has been the key to your commitment towards this philosophy, Intermountain's commitment? You know, the leadership certainly seems to be all in on this strategy. What has been the key towards that commitment?
Well, I think that's just it, Scott, is senior leadership agreeing this is the direction we're going to go. Very often I hear from organizations say that they're still debating amongst their C-suite, should we do this or not? I've had a number of organizations tell me that they're dabbling in population health, but haven't made
Right.
mention of it to their board. For us, our board is deeply involved in this, has been through all the details, very supportive of it. We've taken this notion about bending our revenue curve and presented that in bond rating agencies.
Wow.
So we've pretty much put it out there, and I think that is absolutely the key, Scott, is that senior management has settled on a strategy, has made it clear that's the direction we're going.
Yeah, that's great. We have a lot of organizations, Joe, that are listening to this webinar, and a lot of them are different than Intermountain Healthcare, right? Intermountain owns Select Health, has a health plan, owns the hospitals, owns the physician group. Can organizations that are different from Intermountain move in this direction? And maybe what are some of those steps that some of these organizations can take to move in this sort of shared accountability direction? Any thoughts there that you might have?
Yes, very, very good question. I'm asked that frequently. They say, well, gee, Intermountain, you have the resources to do this. We can't do it. I don't think I believe that. I think that every market's unique, and I think that any organization, whether a payer or a provider that wants to participate in this can. So where you don't own the insurance company, I think you want to find one that you can partner with. Insurance companies have a lot of really good data experts. I mean, they really are population health companies. That's what insurance companies have been doing. And so they bring data, resources, expertise. If you can find a payer in your market that is philosophically aligned and wants to work with you, I think go make a partnership. And then if you're a provider that you don't have enough facilities to really cover a geographic market where you can take a population contract, you need to also make partnerships with other providers. So that collectively with partner providers and a partner payer, you can put together this model and go sell it in the market and say, here's a population model. I think there are a lot of ways to approach this.
That's great. What has been your experience with the commercial insurers in your market beyond Select Health? And what has been their response as you've shared this shared accountability strategy with them in working with them? Certainly it's easier to work with Select Health, right? But perhaps working with some of these other commercial insurers might be tougher. What has been your experience with sort of on that commercial payer side?
Yeah. As we think about a really interesting and daunting time to be a provider, it's also no doubt an interesting time to be a payer. Where all of us are trying to think about what should the future look like and what should our company do and what role should we play. I think there are a lot of players that are being very forward-thinking and saying, yes, we can create a different model for the country, and we can play a different role. And we're finding a lot of payers are very interested in saying, yes, we philosophically are aligned. How can we reform this relationship to where we both have an important role and many things to contribute, but we can bring our assets to bear in creating better outcomes for our community?
Yeah, great. Another question that I had is you shared that great graphic of the various MSSP programs, the bundled payments, the CMS programs, then you had shared accountability up in the top right corner. Do you, in your opinion, do you feel that some of these CMS ACO programs are helpful in moving the country in a good direction, or hindering, or do they help to? That graphic sort of suggested that they sort of moved up toward shared accountability. What's your opinion about the programs that are coming out of CMS?
Certainly ACA and ACOs, I think, have been a huge catalyst for the country and have really helped get some fire under some feet. And I think as an industry, those have really helped to move us. So in that sense, I'd say they've been great. I think they've even inspired a lot of private ACOs, and so I think they've been helped to move the industry move. There are a lot of providers around the organization that are still sitting on their hands. And I think that's where CMS is coming out and making some of these mandatory and trying to push the market. And I can see where they're doing that. For me, for our organization, it's not helpful to make things mandatory. You also take something like CPC or CPC Plus or CCM. A bit of these coming out. I guess those are good for organizations that want to start one step at a time. We're going to start with care management. I think that's great to have a variety of options out there. To me, I'd prefer that CMS did not make these mandatory for those that are already actively working on a particular strategy, and this might just take some resources away from what we're already pursuing.
Yeah, that's great. Joe, anything that we missed during this session that you'd like to share just to wrap up?
I would just say I think this is really a very exciting time to be in healthcare. I think we hold the future in our hands, and what we come out with 5 or 10 years from now is entirely up to us.
That's great. Joe, thank you so much for joining us. This
has
been very helpful, and we've enjoyed listening to you and understanding Intermountain's philosophy. Again, thanks to Joe for sharing his insights and perspectives today. We're thankful he was able to join us, and so all of you know, an audio recording of this conference call will be made available and will be included in our weekly news summary, so look for that. The next webinar will be on November 16th on the topic Developing Alternative Payment Models for Specialists in Specialty Care. In particular, we'll be looking at the OCM, the oncology care model, and our guest presenters will be announced at a later time, so we'll let you know who those folks are that will be participating on that webinar. If you have any questions about the ACLC or follow-up questions about this webinar, please email members@accountablecarelc.org, and we'll get to your questions. We'll answer those. Thank you for joining us, and we hope that you found that this presentation has been helpful and valuable to you. Have a nice day. Bye-bye.